Yeah, good afternoon, everyone. Welcome to yet another edition of continuing education webinar series from Vijaya Diagnostic Center. I thank you all for joining us today. I am Dr. Jnankumar Chaudhuri, and I am the senior consultant in the Department of Biochemistry at Vijaya Diagnostic Center. Today, we are presenting the topic newborn screening and to be presented by Dr. Anila Sushma. Newborn screening is to detect inborn errors at the earliest possible time and with an intention to prevent the more serious after effects. Our presenter today, Dr. Anila Sushma, is a consultant biochemist at Vijaya Diagnostic Center. She completed her MD in biochemistry from Ashram Medical College in 2012 and has nearly 10 years of experience in the subject. If you have any questions during the presentation, please type them into the question box in your control panel and I'll bring them up after the presentation and we'll also have time for the questions at the end. Now, without further ado, we'll turn the time over to Dr. Anila Sushma. Dr. Anila, please, you can continue.
Good afternoon, sir. I thank Vijaya Diagnostics for giving me this opportunity, for giving me this presentation on newborn screen. Let's start with the presentation. This is basically about the awareness of on the newborn screen, and it mainly tells about the concept of the newborn screening, and this will take about approximately 20 to 25 minutes. Coming to what is newborn, coming to the topic here, this will be covered under this topic. What is newborn screening? Why is it needed? How are the disorders selected for the newborn screen and the process of newborn screening? Coming to the why do we need newborn screen and what is newborn screen? It is mainly to recognize the inborn disorders at the earliest possible so as to prevent the most serious problems or the complications of that particular disorder. If in positive cases, the presentation of the disorder can be serious and may affect the normal living of the infant. If the disorders are confirmed, early treatment and timely intervention is required for further management of the disorder. It gives the quality life to the infant, to the affected infant, if the intervention and the treatment happens timely. This due to which the morbidity and the infant mortality reduces. Screening tests are not confirmatory tests. If the report shows positive for any disorder that is analyzed in the screening, it needs further workup. The selection is mainly based on the incidence of the disorder present in India. In India, why few disorders are selected for the newborn screen? It is basically due to the consanguineous marriages happening in India, due to which many congenital disorders are happening. In order to recognize and diagnose at the time, at the particular time before mishap happens, this newborn screen is required, and therefore it is a program. It's a public health program which is happening in India. Coming to the newborn screen program in India, which was done by ICMR in 2014, and this publication was uh, uh, given in 2014. They had analyzed 1 lakh baby infants for newborn screen, out of which 1,000 were admitted in ICU having inborn errors of metabolism. And they have concluded that they established the incidence of congenital hypothyroidism and congenital adrenal hyperplasia in Indian population and prevented disability, and timely intervention helped to prevent disability in affected newborns following good treatment. They have categorized these disorders under 3 phases. Phase 1 is congenital hypothyroidism and deafness. Phase 2 sickle cell disorders, congenital adrenal hyperplasia, galactosemia, biotinidase, and G6PD disorders. Phase 3 consists of other inborn errors where they are very rare compared to the above ones, compared to the above mentioned ones. Coming to the type of sample and the type of testing happening in India, it is a heel prick test. They have suggested to collect dried blood spot for every infant who is born um, even in the urban or rural areas. This is suggested because the dried spot is better to is a proper sample which can be transported in any form through courier, through post, and it is easy way to reach any diagnostic lab in India from the rural areas also. So, what is the type and the time of collection? Heel prick test, it has the dried blood spot which is applied to the filter paper given to the primary care or tertiary care wherever the infants are born. And the time of collection is ideal is 72 hours. Out of the convenience of the patient, it can also be collected after 24 hours of birth. If the baby is on parenteral nutrition, it is to be mentioned on the test requisition because the nutrition which is given in parenteral form might interfere with the drugs with the analysis part. And even if the baby is on transfusion, it is suggested to collect the sample after 2 days of transfusion because it might interfere. The transfused blood may contain the normal RBCs or the normal enzymes, where the affected baby when get transfused, this will give interferences and may give false negative reports if the sample is collected within 2 days of transfusion in an affected baby. The spots to be applied properly as shown in the figure. The filter paper will have 3 spots. Some filter paper will have 4. Based on the number of the areas given on the filter paper, it has to be applied very evenly and regularly. Coming to the newborn screen panels that are included in India and happening in India. They mainly included six disorders where these are included: congenital hypothyroidism, congenital adrenal hyperplasia, galactosemia, biotinidase, phenylketonuria, and G6PD. Coming to the screening part, we'll go one by one according to the name of the test. Once it is confirmed in the screen, it doesn't mean that the baby is affected. It needs to be confirmed by other methods other than the methods used in newborn screen. We will go through the confirmatory test one by one according to the disorders. Congenital hypothyroidism. There is inadequate production of thyroid hormone. If not treated early, they might develop mental retardation, reduced growth, neurological problems, might develop autism also. And the test whenever there is a screen positive in newborn screen, we need to go for further confirmation by testing thyroid profile like T3, T4, TSH levels in serum samples of the baby. And the method used is chemiluminescence or electrochemiluminescence. This diagnosis can be made within 12 hours after the screen is positive. And when the diagnosis is made within 13 days of life, and proper intervention is taken, and the treatment can give a quality life to the affected baby. There's a case scenario I'm going to share with you. This is a case of a newborn born to a born birth by normal delivery, and the screen is sent on third day of admission. The reports have come after 24 hours of the sampling, and the test results showed high TSH value of 137, which is to be less than 10. Now coming to how to follow it up. How to follow it up. This, once the screen is positive, we have ordered for thyroid profile, which consists of T3, T4, TSH in the baby sample in the next 12 hours. And it happened to be coming around 160. This correlated with the screening test, which is positive, and the baby and the pediatrician or the neonatologist or the inherited error of metabolism specialist. There are specialists who look into the inherited errors of metabolism. We convey the same message to all of the above, and they have taken the timely intervention and appropriate treatment was started, whereby this TSH, which is elevated, coming into the category of congenital hypothyroidism, is treated timely, and this will avoid the unwanted outcomes of the inborn errors. This will avoid and prevent. This is to show an example to you. Now coming to the second part of the screening test, that is congenital adrenal hyperplasia. Mainly it is due to the deficiency of 21 alpha hydroxylase, and to confirm this is a screening test, and it happened to be positive. Suppose the baby is affected with 21 alpha hydroxylase enzyme deficiency and the screening test is positive. It is confirmed with the enzyme assay, which analyzes 17-hydroxyprogesterone. Coming to the disease and the introduction of the disease, the adrenal gland usually secretes the hormones like cortisol, no, aldosterone, testosterone, all the six hormones. When there is deficiency of particular enzyme, it can affect any of the hormones in that particular infant. For suppose if the aldosterone is produced, the less amount of aldosterone is produced less, that can lead to salt losing condition where the sodium or the electrolytes are lost in the sodium is mainly the sodium is lost in the urine, coming giving a dehydrated state, making the baby go into a dehydrated state. It can also affect the sex hormones where they can present with single virilization disorder, where the female can look like a male. So early detection of this kind of disorders can prevent the serious outcome of the infant, of the affected infant. They are on early treatment with glucocorticoids. This will benefit the infant. Coming to the third part of the screening newborn screen, that is galactosemia. And galactosemia main component, the galactose is the main component of breast milk and infant formulas. There are two main enzyme deficiency which are involved with this disorder. When there is deficiency of one enzyme, that will lead to any one of the enzyme, that will lead to the accumulation of galactose in the infants. That might present with feeding problems, bleeding, infection, or liver failure, develop cataract, or even mental retardation. So, timely intervention after the screen is positive for galactosemia, we need to confirm it. The confirmatory test is done by tandem mass spectrometry, and the treatment followed by the proper treatment and the intervention. The treatment would be lactose galactose restricted diet, or the formula feeds having low content of galactose or lactose. Early detection before 10 days of life will benefit the quality of baby's life. Biotinidase. Biotinidase, it is required for the carboxylation reactions in the body. Upon its deficiency, biotin is not recycled in the body. Therefore, the affected babies may develop metabolic ketoacidosis, organic acidurias, and hyperammonemia, which might present in the form of seizures, hypotonia, ataxia, developmental delay. As this is a screening test, it needs to be confirmed by tandem mass spectrometry, that is the enzyme analysis. And the treatment followed by the confirmatory test is 5 to 10 milligrams of biotin, which is given for the longer time, that will prevent all the symptoms mentioned above. Coming to the fifth part of the newborn screen, that is phenylketonuria. Affected babies present with mental retardation, and if this phenylalanine is deposited in particular organ, it leads to the organ damage. The confirmatory test is very easy. The urine of the affected baby can be tested by tandem mass spectrometry. And the treatment would be the aspartame restricted diet, low protein diet, like we have seen for galactosemia. Coming to G6PD, G6PD is glucose 6 phosphate dehydrogenase deficiency, which can also be done in this newborn screen. They have a picture of anemia with hemolytic picture. Anemia is described as the low content of hemoglobin, where the RBCs get lysed. The RBCs in the blood will have this enzyme called as glucose 6 phosphate dehydrogenase. Due to the deficiency, there is a breakdown of RBCs which will lead to hemolysis. The additional tests which would help for the G6PD are even the liver function test, complete blood picture can help with the G6PD deficiency. It is a screening test and should be confirmed by the colorimetric method. The treatment for G6PD would be symptomatic, that is called as palliative treatment. It means that the triggering factors should be avoided, like infection, and if in future, if the affected baby is contracted with the malaria, they should be cautious about using primaquine. There will be drug interferences in G6PD deficiencies. Coming to the other rare disorders where these are not included in newborn screen, because the incidence of the following disorders which I'm going to say are less in number in population. They are less in number in population. Those include amino acidurias, organic acidurias, and fatty acid oxidations. Coming to the individual parts, hemoglobinopathies are little commoner than the remaining rare disorders. The hemoglobinopathies like sickle cell disease, hereditary spherocytosis, these can be detected in complete blood picture of the baby having a high bilirubin or deranged liver function test. Coming to the amino acidurias, 1 in 5,000 babies can be affected with these kind of disorders, and they might, to name few, maple syrup urine disease, tyrosinemia type 1, homocystinuria, citrullinemia. And to name few of the organic acidurias where we can see 1 in 20,000 births. To name few, this cystinuria, there can be anything involved with the amino acid along with the fatty acids. There are other conditions like fatty acid oxidation disorders, and there can happen. The incidence of fatty acid oxidation disorders is very low. That is 1 in 12,500 births. The basic workup for these rare disorders are not involved in the newborn screen, which is done in the earliest of the life. Therefore, over the period when a baby is developing failure to thrive, or there are any feeding disorders or feeding difficulties, or there are delayed milestones, these rare disorders should be considered. These rare disorders can be analyzed through expanded or comprehensive panels, which where only few labs does. There are panels of 49 disorders involved, 51 disorders and 55 disorders also can be analyzed. The take-home message is the ELISA or the immunoassays are the methods used for newborn screening. If the screening test is positive, it should be confirmed by tandem mass spectrometry method. If the confirmatory tests are positive, it is advised to visit neonatologist or inherited errors of metabolic specialist for further intervention and to avoid the bad outcomes of the affected babies.
So, thank you, Dr. Anila, for a very informative presentation on this important subject. And now we'll go ahead and take some time for questions now. Just a reminder that please be sure to type your questions in the question box in your control panel. So it looks like we have some questions. Yeah, one question from Dr. Vikas. When is the correct time to take samples from preterm babies and why?
So the preterm the weeks mentioned for the term and preterm is 37. The cutoff above 37 is term, and the cutoff less than 37 is named as preterm. Once we have to take the sample from preterm, we have to wait for 2 weeks till the baby gets to the normal. because all the metabolism doesn't are not matured enough to produce enough substrate or enough enzymes in during the preterm phase. So once the baby attains the term and is doing well with the feeding, it is better to screen after 2 weeks.
The second question, why is DBS selected for newborn screening?
Yes, this newborn screening is a public health program which is initiated by many states. So, in order to reach the rural population, this filter paper dried blood spot is suggested. When you collect a venous sample or any sample, capillary sample, blood sample in normal vacutainer, the time it reaches to the analytical lab, it takes more time, and in meanwhile it can get clotted or which is not appropriate for the testing. So to avoid all this, the dried filter spot test is advised, and it is validated over 1 lakh babies or infants by the ICMR. It is easy to courier a filter paper from any part of the India to the particular analytical lab. That is why the spot filter paper is preferred over the venous or the capillary sample for the analysis.
Thank you. Now, another question, does all laboratory do comprehensive panel?
No, they don't do. In Hyderabad, we could see four or five labs doing the comprehensive studies analysis. The screening test can happen in any part of tertiary care hospital, or most of the labs does newborn screening. But coming to the confirmatory test, where we only see tandem mass spectrometry, those are robust instruments which are maintained by and there is an NABL accreditation which is very stringent about their testing. Not all labs do these comprehensive panels, and because there are less in number also. The screening test can happen many, but the confirmatory tests are very less in number. Therefore, only 3 or 4 labs does this comprehensive panel, which will have 49 disorders, 20 disorders as per the requirement of the clinician.
Like, is there anything else to share before we can wrap up from your side? Dr. Anila, please.
Definitely, the newborn screen is a public health program which needs to be done to every newborn, at least the screening test. We won't be able to afford for the comprehensive panel, but at least due to the consanguineous marriages are there in India, due to which there are more congenital deformities or disorders happening in India. These newborn screens are recommended for all the infants at any area, rural or urban. Thank you, sir. Thank you for giving me this
Yeah,
opportunity.
great. Thank you, everyone. Now, we appreciate all of you being here. A recorded version of this webinar will also be available. Thanks again for joining us today, and we'll see you next time.
Thank you, sir.